Hello, namaste students. Today we will be discussing about one very important case for both undergraduate and postgraduate students. This case will be kept as a short case for undergraduate students as well as postgraduate students in some of the university exams. But because there is no short case in DNB exams, a short relevant history also will be discussed here, because in DNB exams there is only semi-long cases where history you have to take. Whereas in some of the universities, there will be a short case and long case, and undergraduates, there will be a short case and long case where history is not needed. In those universities, this case will be kept as a short case. But for DNB students, this can be a semi-long case. So that's why I want to discuss about briefly about the history of this patient. Okay. So today we'll be discussing about a connective tissue disease disorder, which is a commonest connective tissue disease disorder, that is rheumatoid arthritis patient. Okay, students, right. So the patient name is X. He is aged about 35 years and he is a male, and occupation is a lift operator in one of the hospital in Bangalore. He stays in Bangalore. The chief complaints are pain and swelling of the right thumb. 20 years back in 2000 year. In 2000 he got pain and swelling of the right thumb, and then it is followed by involvement of all the other fingers in the right hand within 1 month. So right thumb first involvement 20 years back, and then involvement of whole of the right hand in 1 month. Later then he got involvement of the left hand in 3 months, okay, and then he started developing deformity of the hands. Knee joints, he says there's a pain and swelling which is symmetrical in both right and left side, and difficulty in getting up from squatting position because of the pain in the knee joint. So he developed that over the 1 year. Then he also developed deformity, and he told he needs support for standing because of the deformities which he developed. Then 5 years after he developed 2000 years all these joints involvement, he developed deformities of both the foot. Both the foot he started developing the deformities, and he is not able to bend his right knee since 2005. There is difficulty in lifting both the shoulder, and the shoulder was associated, lifting of shoulder was associated with the pain in both the shoulders, and left more than right, he says. So he gives history of multiple joint pain, students, both upper limb and lower limb, which is symmetrical in onset. Whenever they come with a symmetrical onset polyarthritis means more than involvement of the joint, more than 4 joints is polyarthritis. So it's a polyarthritis involving both the small joints, okay, and some of the large joint also, knee joint also is involved in it. Whenever they come like this, one important point you have to ask in the history is whether to rule out, whether to differentiate whether it is inflammatory or non-inflammatory arthritis. A very important point is early morning stiffness, which will relieve with the activity, is a feature of inflammatory arthritis. Whereas the pain, okay, which will aggravate with the activity is a non-inflammatory arthritis like osteoarthritis. This point you have to remember, students, throughout your life while in practice also, okay. The early morning stiffness, okay, which will relieve the pain, and the stiffness which will relieve with the activity is inflammatory arthritis. Most of the arthritis are inflammatory arthritis. The only important non-inflammatory arthritis is osteoarthritis. The other arthritis like psoriasis, SLE, current issue diseases, rheumatic fever, these are all inflammatory arthritis. Okay. The only non-inflammatory arthritis is osteoarthritis. Okay. And I'll tell again detail when I tell about how you approach a joint disease when I discuss in the end the theory part. Here in the history wise now, whatever he is giving the history is, there is both involvement of large joint and small joint, symmetrical in onset, polyarthritis, involvement of more than 4 joints, and the two mainly small joint, and there is also a large joint involvement in the form of knee joint involvement. So that is why we asked him in history. Here he says history of early morning stiffness, which is lasting for around 1.5 to 2 hours. Okay, and then that early morning stiffness will ease while during the activity. That specific point he says today. So this is the inflammatory arthritis, polyarthritis, symmetrical involvement. So whenever they say like this, and chronic duration, that duration is more than 6 weeks. So whenever there is a history of more than 6 weeks duration, a chronic, and then there's the inflammatory arthritis because morning stiffness and release with taking the during the activity, and polyarthritis symmetrical. So then what are the DDs you will consider if it is like this? Then you will consider the DDs. Suppose if the involvement on examination, okay, if the involvement of the metacarpophalangeal joint, proximal interphalangeal joint, wrist joint, or the tarso-metatarsal joint, then it is rheumatoid arthritis. It is rheumatoid arthritis because of those joint involved. If those joints are not involved, if it is a polyarthritis, okay, if it is a symmetrical, then you will consider SLE, okay, then polymyositis, misconditioned disease disorders. Suppose if it is a inflammatory arthritis, and if it is involving less than 3 joints, then what are the diseases you will consider? If it is inflammatory arthritis, less than 3 joints, then you will consider tubercular arthritis, or a fungal infection, psoriasis, or a reactive arthritis. Suppose if it is a more than 3 joints, a polyarthritis, inflammatory, if it is asymmetrical, then what are the diseases you will consider? If it is asymmetrical, then again psoriasis can sometimes involve the more than 3 joints, a reactive arthritis, and enteropathic arthritis. For example, inflammatory bowel disease arthritis can have a polyarthritis, okay, but it is asymmetrical. Again, I'll discuss how you approach a joint pain, okay, and I'll come back to that again. In the histowise, I think this much is enough. Next point is, he says history-wise the pain will increase during the cold, and also there is no pain during summer. He says there is environmental affection on the pain. Then he says history of fatigue, breathlessness and exertion. So these points you have to ask because he has polyarthritis, symmetrical. Probably we are considering at this history only, probably suffering from rheumatoid arthritis. All these arthritis, whether rheumatoid arthritis or SLE, all these arthritis will have extra-articular manifestations. So what are the extra-articular manifestations relevant to those points? You have to ask in the history some of the points. So history of fatigue, okay? Fatigue, constitutional symptoms like fever, depression, weight loss. These are commonest extra-articular manifestation of rheumatoid arthritis. The number one extra-articular manifestation. So he also says history of fatigue because of the chronic inflammation, whatever they're having in the body, they'll have this fatigue. Breathlessness, you have to ask, he says there is breathlessness and exertion. Probably the breathlessness could be due to the anemia is possible, or it can involve the lung disease, interstitial lung diseases, a pleuritis. Interstitial lung disease, the two types are usual interstitial pneumonia, non-specific interstitial pneumonia can involve rheumatoid arthritis, ILD, and then it can involve pleura. Then cardiac involvement, it can produce myocarditis, congestive heart failure, coronary artery disease. So history of breathlessness is important in rheumatoid arthritis patient, whether he is breathlessness or not. He also says history of giddiness. Okay, giddiness probably a part of anemia if he is suffering from, probably a part of anemia. Okay, or very rarely the rheumatoid nodule may present the conduction system producing a blocks, AV blocks. Okay, right. He says history of weight loss, 3.5 kgs in the last 6 months. As I told, is one of the constitutional symptom, weight loss. One of the commonest extra-articular manifestation of rheumatoid arthritis is these: fatigue, weight loss, fever. Okay, right. Then history of bone pains relieved on taking injections. Probably the associated conditions of rheumatoid arthritis. One is the cardiac conditions, associated condition. Another is the osteoporosis, and another is effect on the FSH, LH, and testosterone. These three are the associated conditions in rheumatoid arthritis. So they have osteoporosis here, though the problem is with the joint. The inflammation in the joints, the milia, will spread to the whole body, and because of that inflammation, they can develop osteoporosis. Not only because of that, because they are immobile, because of the joint pain, and because they take steroids, which can produce osteoporosis, and steroid therapy, because they use steroid therapy, immobility, and whole body inflammation can produce osteoporosis, which can produce bony pain. So that is why you have to ask history of bony pain. The patient says history of bony pain is there, which is relieved on taking medication. No history of chest pain, no history of leg swelling, and no history of fever, or no history of Raynaud's phenomena. Raynaud's phenomena is important because a secondary Raynaud's phenomena can occur. A primary is a Raynaud's disease where there is no etiology is found. Secondary could be due to connective tissue diseases. They can develop, that is the Raynaud's phenomena you have to ask, as extra-articular manifestations. And there is no history of any swelling in any of the body. So I repeat, what are the things in the history you have to ask, especially in a case like this? Okay. So the constitutional symptoms like history of fever, weight loss, and malaise, and whether they are having history of any nodules, Some patients, they may find nodules in the body because of the rheumatoid nodules. They may come to you with the nodules. Okay. So any history of nodules you have to ask. Then as I told, palpitation, breathlessness, syncope and pedal edema to rule out cardiac disease you have to ask, as well as the respiratory symptoms. Raynaud's phenomena, then symptoms of anemia like easy fatigability and bony pain to rule out osteoporosis. Okay. There are the extra articular manifestations. So relevant to those points you have to ask in the history. So next coming to the general physical examination. Okay, right. Before going to the general physical examination, now here only I want to discuss the approach to a case of arthritis. How you approach to a case of arthritis. So, in an approach to a case of arthritis, whether the patient is really having a joint problem, a tendon problem, ligament or muscle problem, you have to first confirm whether whatever the problem the patient is having. Then suppose if you are sure that the problem is within the joints, then you have to ask whether the patient is having inflammation or not. Inflammation could be by the soft tissue swelling, the pain, or the raised ESR and CRP on investigations. So inflammation is there or not. Then duration, for how many days the joint pain is there. If it's more than 6 weeks, then it is a chronic. Less than 6 weeks, usually we consider it as an acute. So more than 6 weeks, less than 6 weeks. So the duration is important. Then inflammation is important. Then you have to ask whether how many joints are involved. How many joints are involved. Okay. So usually it is classified as a monoarthritis where single joint is involved. Oligoarthritis, less than 4 joint is involved. More than 4 joint is polyarthritis. So then inflammation, one more point is in the history wise only you can ask whether early morning stiffness is there, which will really be taking the medications. So this patient gives that history, so it's an inflammation and he has a joint pain. The problem is within the joint, arthritis. The duration is more than 6 weeks. Since 20 years he is having the problem, since 20 years, and more than 4 joints is involved. It is a polyarthritis. So that's the first approach to a evaluation of a joint pain. Then if a single joint is involved, if the duration is less than 6 weeks, then what are the conditions you will consider? If a single joint is involved, if the duration is less than 6 weeks, septic arthritis, gout, pseudogout. These are the causes of a single joint involvement, acute less than 6 week duration. Then if it is a more than 6 week duration, then you have to ask whether how many inflammation is there or not, if more than 6 weeks duration. Suppose if signs of inflammation is there, history you consider it as an inflammatory arthritis and more than 6 week duration, then how many joints are involved you have to see, whether more than 3 joints or less than 3 joints. Suppose the signs of inflammation is not there, if the patient doesn't fit into an inflammatory arthritis, early morning sickness is not there, and the pain increases during the activity, then what are the diseases we will consider? So the only important non-inflammatory arthritis is osteoarthritis. So in osteoarthritis, the carpometacarpal joint, especially the first carpometacarpal joint will be involved and distal interphalangeal joint will be involved. Very important, students. The disease which we are considering a rheumatoid arthritis, distal interphalangeal joint is not involved. Whereas in osteoarthritis, distal interphalangeal joint will be involved. There is a proverb, hip and dip are not involved in rheumatoid arthritis. Hip and dip are not involved in rheumatoid arthritis. So either distal interphalangeal joint is involved, carpometacarpal joint is involved, hip joint is involved, knee joint is involved, then it is osteoarthritis. Suppose if these joints are not involved and still if it is a non-inflammatory, there are other rare conditions like hemochromatosis, osteonecrosis and Charcot's joint are non-inflammatory, but these typical joints are not involved. Distal interphalangeal, carpometacarpal, hip joint and knee joint. Hemochromatosis, Charcot's joint, okay, and osteonecrosis. Now we'll come back to the inflammatory arthritis. More than 6 weeks, inflammation is there in the 2 types, whether less than 3 joints are involved, more than 3 joints are involved. If more than 3 joints are involved like this, then you have to see whether it is symmetrical or non-symmetrical. If it is symmetrical, in the symmetrical, if the metacarpophalangeal joint, proximal interphalangeal joint, wrist joint and torso-metatarsal joint, if it is involved, then it is rheumatoid arthritis. Suppose if it is an inflammatory, more than 6 weeks, more than 3 joints are involved, but if these joints are not involved, the joints which I told, okay, the proximal interphalangeal, metacarpophalangeal joint, wrist joint, if it is not involved, then you have to consider SLE, polymyositis, misconnective tissue diseases. Suppose if inflammatory more than 3 joints, it is non-symmetrical, then psoriatic arthritis, retus, the reactive arthritis, the retus arthritis, and enteropathic arthritis, like inflammatory bowel associated arthritis. It will be asymmetrical there. And more than 3 joints will be involved, and it is inflammatory arthritis. Suppose if it is less than 3 joints are involved, inflammatory, less than 3 joints are involved, then tubercular arthritis, fungal infection, tubercular arthritis. Again, psoriatic arthritis sometimes can be less than 3 joints, and reactive arthritis can be sometimes less than 3 joints. So this is how you approach a case of arthritis. Hutchison says predominantly symmetrical, both upper limb and lower limb is rheumatoid arthritis and SLE. Predominantly symmetrical in upper limb is hemochromatosis involving the middle finger and index finger. Predominantly asymmetrical is psoriatic arthritis, and predominantly asymmetrical in lower limb is reactive arthritis and ankylosing spondylitis. Yes, given in one table. Okay, right. This is how you approach a case of arthritis. So he fits into the rheumatoid arthritis. The joints involved are according to his both the hands, elbow, shoulder, knee, and foot. These joints are involved in it. Okay, students, right. This is how you approach a case of arthritis. Now, relevant to this case, what are the things you see in the general physical examination, top to bottom? Let us discuss. No history of pallor. So, on examination, there is no pallor. Okay, pallor important because again, one of the extra-articular manifestation, hematological manifestation of rheumatoid arthritis, they can have normocytic normochromic anemia because of anemia of chronic disease. It's a chronic disease. Icterus, there's no icterus. Probably icterus relevance is a drug induced, probably a drug if it's taken for rheumatoid arthritis, like a JAK inhibitor. Okay, that can produce icterus or a methotrexate due to liver toxicity is a possibility. Clubbing is important because clubbing, they can have, because of the interstitial lung disease, okay, they can have a clubbing in a rheumatoid arthritis. So, clubbing you have to see whether clubbing is there or not. Cyanosis, again due to interstitial lung disease of the rheumatoid arthritis, they can develop cyanosis. So, you have to ask any history here. So you have to look for cyanosis. Pedal edema, there is no pedal edema, he is not having any pedal edema. Lymphadenopathy, one of the extra-articular manifestation of rheumatoid arthritis is lymphoma. They are more prone to develop large B-cell lymphoma. So, in that relevance, probably lymphadenopathy is important. Okay, then you have to look for that. Then the other things which you look top to bottom is any petechiae is there, you have to see petechiae, okay, and purpuras, petechiae and purpura, because they will have vasculitis as one of the extra-articular manifestations. So, they will have petechiae and purpura. You have to look for any petechiae and purpura. Any digital ulcer, you have to look digital ulcers, okay, again a manifestation of vasculitis. And subcutaneous nodules specifically, you have to look students. So, which are the areas you look for subcutaneous nodules? You have to look for in the extensor aspect of the forearm, sacral bone, and the Achilles tendon. Wherever there is a more friction, there is subcutaneous nodules will be there. Subcutaneous nodules is one of the commonest extra-articular manifestation. Of late, it is reducing. The incidence is reducing. Before it was 30 to 40%, the incidence. Subcutaneous nodules is more common in patients who are having a more disease activity, okay, and there are some, those who have a disease shaded epitopes, and those who have a bony erosions, and those who have rheumatoid factor positive in them, it will be more common subcutaneous nodules. They are painless, they are benign, but they can ulcerate and they can produce a gangrene. Subcutaneous nodules need not only in the body, it can occur in the lung, peritoneum, heart, it can occur in all the places. Okay, subcutaneous nodules. And there is no libido reticularis on examination. Again, that you have to look, okay, for because vasculitis can have a libido reticularis. So, you have to look for those things. So, just I want to summarize the general physical examination. What all you want to look in these sort of cases: pallor, edema. And edema, one more cause could be due to the amyloidosis, the secondary amyloidosis, rheumatoid arthritis. They can have an nephrotic syndrome. Probably you can think in that term. And the nails clubbing due to ILD. Cyanosis again due to ILD. Ictus probably due to the drugs. Lymphadenopathy because of the lymphoma and rheumatoid arthritis. Probably you may have to look. Then fever, subcutaneous nodules, Then eye manifestations, scleritis, episcleritis, you have to look. Rheumatoid arthritis, scleritis and episcleritis can occur. Okay, so you have to look for that. Then petechiae, purpura, infarct, gangrene, ulcers, and livedo reticularis for a vasculitis manifestations. Okay, students, right. So the coming to the vitals, temperature is normal, pulse rate is 82 beats per minute, blood pressure is 110/70, respiratory rate is 16 cycles per minute, and all peripheral pulses are felt. So now, because this is the arthritis case, now first we'll examine the locomotor system, and then we'll go for the examination of the each system. So in the locomotor system examination, students, as HSN gives, first you have to see galls and then these specific joints you have to examine. So we'll go in that order only. Gait, I'll show at the end of the discussion because I don't know disturb him now with the gait and examination of the further things. I'll show the gait at the end of the discussion. So we'll switch on to the arm, spine and leg. So first I'll show spine, what are the things you will see. So students, let us examine the spine. So normally there will be a thoracic kyphosis and cervical and lumbar lordosis. This is a normal thing. So whether it is there, you have to see that. Then you have to look for any kyphosis or scoliosis. Is there, you have to see it. And then spine you have to examine sideways and back. Okay. Sideways I'll be examining the spine and then the back. So back you have to see. So here the cervical lordosis and lumbar lordosis will be maintained. It is maintained here, and this is normal thoracic kyphosis. Thoracic kyphosis is there. There is no exaggerated kyphosis or abdominal kyphosis, or not even scoliosis present. That is also not present. Okay, right. Then other things you look in spine is the cervical spine. You have to look for a flexion and extension. Manjuna, cut marchkobekinge, marchkoli. Yeah, this is a flexion. You have to look for this. Then extension. Cut in the marchkoli. Yeah, so flexion and extension, you have to look for that. Then in the spine, you have to look for the bending. Okay, the forward bending. It has to bend to the ground. The distance between the ground and the thumb should be less than 15 centimeters. That should be there. And the lumbar spine should expand by more than 6 centimeters. Okay, so let us see whether he can bend, how much he can bend to the down. Students, then you have to examine for the spine, okay, for the forward bending. While forward bending maximum, the distance between the floor. Students, next examination in the spine is forward bending. While forward bending, the distance between the floor and the finger should be less than 15 centimeters. So let me measure it. Manjunath, bend ಮಾಡಿ ನೀ bend ಮಾಡಬಾರ್ದು ಎಷ್ಟಾಗುತ್ತೆ bend ಮಾಡಿ ಅಷ್ಟು ಚೆನ್ನಾಗೋದು ಅಷ್ಟೇನಾ So I'll take the measurement. Right side it is 34, left side it is 44. So it is abnormal. So normally it should be less than 15 centimeters. And while on bending down, you have to look for the lumbar expansion. That I'll demonstrate again while I'll discussing the examination at the spine. Because I made a mark on the back side, I'll explain that the lumbar expansion when I examining the lumbar spine and thoracic spine in detail in examination of each joints. So these are the things which you look in the spine examination. Now, what are the things you look in an arm examination? So gait I'll tell in the end while making walk. Arm examination. Arm examination, what are the things you will look? Okay, arm examination, students. The patient first he should lift the arm above the head 180 degree. Manjunath, ನಾನು ಮಾಡೋ ಥರ ಮಾಡಬೇಕು. ಕೈ ಹಿಂಗೆತ್ತಿ ಫುಲ್ ಮೇಲಕ್ಕೆ ಆಗಲ್ವಾ? Yeah. So there is a restriction, student. So he can lift only till that level. This is the raising the arm above 180 degree. And then next you have to ask the patient looking. Manjunath, ನಾನು ಮಾಡೋ ಥರ ಮಾಡಬೇಕು. ಕೈ ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ. Hold the hand like this and then do like this. ಹೀಗೆ ಮಾಡಿ. Yeah. So he is not able to do that. He has to do that. Then students, ask him to do a prayer sign like this. Manjunath, hige ಮಾಡಿ. Not able to do that, students. Manjunath, then inward prayers sign. ಹೀಗೆ ಮಾಡಿ. Yeah. That also is not able to do, students. Is not able to do inward prayer, students. Okay. then you have to ask the patient, okay, to extend the elbow to 180 degree. ಮಂಜುನಾಥ್ ಕೈ ನಿಂಗೆ ಫುಲ್ ಸ್ಟ್ರೈಟ್ ಆಗಿ ಇಟ್ಕೊಳ್ಳಿ. ಸ್ಟ್ರೈಟ್ ಮಾಡೋಕ್ಕಾಗಲ್ವಾ ಇದು? ಅಷ್ಟೇ ಆಗೋದು. ಸೊ he is telling only he can do that much. He is not able to do total 180 degree extension at the elbow joint. ಅಷ್ಟೇ ಆಗೋದು. Right. Then you have to look for the hand. In the hand, ಕೈ ಕೊಡಿ. So in the hand, students, what are the deformities he is having? You have to see here. See, students, full hand focus. Okay, students, let us focus on his hands, where the important focus is the rheumatoid arthritis. Okay, right. Here are some classic findings. I want to describe those classic findings. Okay. See, students, the hand. The first thing is here the ulnar deviation. The fingers have become ulnar deviation due to the metatarsophalangeal joint dislocation in both the hands. In this hand also there is a ulnar deviation. And see the thumb, students, in both the hands. Okay, there is hyperextension at the first interphalangeal joint, hyperextension. Okay, and subluxation of the metacarpophalangeal joint. Here also there is hyperextension at the first interphalangeal joint with subluxation of the metacarpophalangeal joint. This is a classic Z deformity of the thumb. Z deformity of the thumb. Okay, this is Z deformity. You can make out both the hands, the Z deformity. And then, students, here you can see in the fingers, in the ulnar finger, in the ring finger and the middle finger, and here also this finger, the ring finger here, there is a hyperextension. There is hyperextension at the proximal interphalangeal joint, and there is a flexion at the distal interphalangeal joint. Flexion of the distal interphalangeal joint, hyperextension at the proximal interphalangeal joint. This is a swan neck deformity. Swan neck deformity. Extension at the proximal interphalangeal joint, flexion at the distal interphalangeal joint. This is a swan neck deformity. Okay. The opposite, the flexion at the proximal interphalangeal joint, extension of the distal interphalangeal joint is a botnol deformity. Okay, he is having a swan neck deformity here in the ring finger. In the ring finger, he is having a swan neck deformity here. You can make out that. A classic deformity, students. Okay, and one more deformity which you can get in the hand is piano keyhole deformity, where the ulnar striated process will undergo inflammation with extensor carpi ulnaris muscle, and then you will have dislocation of the distal ulna, producing a piano key deformity. Okay, so it's having a Z deformity, ulnar deviation, and swan neck deformity of this finger, the ring finger of the left hand. The ring finger of the left hand. So which are the other things you look in the arms? You have to ask the patient to hold the hand behind the head like this. Agalva, he is not able to do that, students. He is not able to do that. Okay. The other thing which you look in the examination of the arms is whether he is able to touch behind about T10. So let us do that. Saku ಈಗ ಟರ್ನ್ ಮಾಡಿ, ಈಗ ಟರ್ನ್ ಮಾಡ್ಕೊಳ್ಳಿ. This is C7, T1, T2, T3, T4, T5, T6, T7, T8, T9, T10. ಮಂಜುನಾಥ್ ಇಲ್ಲಿ ಈ ಜಾಗದಲ್ಲಿ ಮುಟ್ಕೋಬೇಕು. ಮುಟ್ಕೊಳ್ಳಿ ನಿಮ್ಮ ಕೈಯಿಂದ ಆಗತ್ತಾ? ಓಕೆ, ಇಸ್ ಏಬಲ್ ಟು ಡೂ ದಟ್. ಈ ಕೈಯಿಂದ ಮುಟ್ಟಿ ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ದಟ್. ಈಸ್ ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ದಟ್. ಓಕೆ, ಸಾಕು ಬಿಡಿ. So other things which you look in the arm is whether he can make a pinch using the middle finger, index finger and the thumb. ಮಂಜುನಾಥ್ ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಿ. ಇದು ಇವೆರಡು ಇಟ್ಕೋಬೋದಾ ಟೈಟಾಗಿ? ಆ ಕೈ ಇಟ್ಕೊಳ್ಳಿ. Yeah, so able to do that. The grip, the pinch grip. Then the hand grip. ಟೈಟಾಗಿ ಇಟ್ಕೊಳ್ಳಿ ಬೆರಳು. Hand grip is okay, the power is normal, only the deformity is the problem. Yeah, hand grip is okay, it's a normal hand grip. So the grip, then you have to look for the metacarpophalangeal joint tenderness. You have to squeeze it. So let me squeeze it. This is the metacarpophalangeal joint. I have to squeeze it. No idea? Yeah, he says there is a slight pain. No idea? Now, he says there is a slight pain. The pain in a joint disease is classified under 4 headings. The grade 1 is the patient says there is a pain. The grade 2 is the patient will winces with the pain. The grade 3 is he will withdraw while palpating. Whereas the grade 4 is he won't allow you to touch. For example, a septic arthritis or a gouty arthritis. Here on pressing, he is saying there is a pain. Probably grade 1 is a grade 1 joint pain. This is what Hutchison gives, the grading of the joint pains. Then in all these joint examination and locomotor examination students, the 3 things inspect, okay, and then feel, and then move. These 3 are the headings. Inspection is you have to inspect the deformities. Then feel is the palpation, you have to palpate the joint, and then move, then you have to move the joints. Under these 3 headings, all the joints, specific joints will be examined. So in the goals, the first is the gait that I'll tell you in the end of the examination when I will make in the walk. Arms, we examine the arms. Now, and also spine also we examine. The last thing in GALS is spine. Spine also we examine. Now let us go into the leg part. Okay. So just I'll summarize what are the things you want to look in the arm part. Okay. He has to raise the arm above 180 degree like this, which is not able to do that. Touch the middle of the back of the T10 with only one hand he can do that. Then straighten the elbow to 180 degree, he couldn't do that. He couldn't straighten the elbow more than 180 degree. And then he has to make a fist. Yeah, that is one more thing. Fist we have to make. Ask him, Manjunath, ee tara ಮಾಡಿ ಹಿಂಗೆ ಇಟ್ಕೋಬೇಕು. Fist very difficult, is not able to make. ಈ ತರ ಇಟ್ಕೋಬೇಕು, ಈ ತರ. ಈ ಬೆರಳದ ಊರುಗಳಿದೆಯಲ್ಲ ಕಾಣಬಾರ್ದು. ಆಗ್ತಾ ಇಲ್ವಾ? I saying not able to do that. Not able to make a fist. So it is to do that. Okay, right. Sir. So make a fist. Okay, and then pray. The prayer sign he couldn't do that. Okay, there are 2 types of thing. One is the prayer sign like this. Okay, he has to do like this. The prayer sign he has to do like this, and the inward prayer sign like this. So students, you have to ask the patient to do a prayer sign like this and inward prayer sign like this. Okay, right, which is not able to do that. And then you have to look for metacarpophalangeal joint compression, any tenderness. He is having a tenderness, he told there is a pain. Okay, and then pinch with the index, thumb and middle finger, and then the palms should be like this. Ask the patient to supine it. Okay, these are things which you look in the examination of the arms. Let us go to the examination of the leg students. So students, now what are the things you examine in the legs? So leg, hip should be flexed, okay, and then knee flexion till 140 degree. That is the first examination. Then the hip rotation 90 degree, both laterally and medially. That you have to do. Then bulge test and patellar tapping, you have to do that. That I will show how to do that. And in the ankle joint and subtalar joint, the movement, dorsiflexion, plantar flexion. Okay, that you have to do. Okay, so let me do the test here. Manjunath, ಕಾಲ್ ಮಾಡಿಸ್ಕೊಳ್ಳಿ ಹಿಂಗೆ. Hip flexion students, you have to do that. Okay, and then you have to flex the knee 140 degree. Look for the crepitus. He is not able to do. He is not able to flex it. The right knee. Okay, students, not able to flex it. The right knee. I am not able to flex it. Then the left leg. Manjunath, ಕಾಲ್ ಮಾಡಿಸ್ಕೊಳ್ಳಿ. Hip flex at 90 degree. Then try to flex the knee. Knee, I am able to flex left side. See students, left side easily I am able to flex more than 140 degree. Okay. But right side, see, there is not able to make the flexion. I am not able to flex it. Next is hip 90 degree rotation. Okay, I will do that. Manjunath, ಇದೆಯಲ್ಲ ಇದನ್ನ ಹಿಂಗೆ ಮಾಡಬೇಕು. ಮಾಡೋಕ್ಕಾಗತ್ತಾ? ಯಾ, towards like that. Okay, ಆ ಸೈಡ್ ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಆಗಲ್ವಾ? Yeah, so he's able to do only that much. With the left side I will do. ಆ ಸೈಡ್ ಮಡ್ಚ್ಕೊಳ್ಳಿ. You can do that. ಈ ಸೈಡ್ ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಆಗಲ್ಲ. Okay, right. Hip rotation. So next is the bulge test. The bulge test, you have to press the patella from above downwards, and with the 2 fingers you have to apply the pressure downwards like this for a bulge test. And then for a patellar tap, you apply the pressure from above downwards. With the 2 fingers, you press above downwards like this vertically. vertically. Whereas for a pulse test, you press the fingers downwards from top to bottom like this. Whereas patellar tap, you press above downwards. You have to see that. And then in the ankle joint, the dorsiflexion, plantar flexion. Okay, students, in the foot, first let us inspect what are the deformities is having. Here is a classic hallux valgus deformity, students, both in the right foot and in the left foot. Classic hallux valgus deformity. And there is callosities. Callosities here and here, there is a callosities are present. Okay. And you can see the arch is last, is having a pes plano valgus deformity. Plus plano valgus deformity. Both the right foot and the left foot, students, there is a planus deformity, pes planus valgus deformity. So students, he has a hammer toe deformity, which I will show now. So here, because of the flexion, okay, at the intertarsal joints, okay, first intertarsal joint, okay, and extension at the metatarsophalangeal joint, sorry, metatarsal joint, extension at the metatarsal joint, and flexion at the first intertarsal joint is having a hammer toe deformity, students. A hammer toe like deformity in the great toe can give a picture like a cock-on deformity, cock-up deformity, cock-up deformity. Okay, the hen cock, how you it will have no the on the head, the same deformity. So here is having a hammer toe deformity of the foot, students. So in the foot, the two movements which you will see is dorsiflexion and plantar flexion. Okay, and the other movements in the examination of each joint I will discuss when I come to the examination of each joint. Okay, right. ಮಂಜುನಾಥ್ ನಾನು ಹೇಳಿದಾಗ ಪಾದ ಹಿಂಗೆ ಮಾಡಬೇಕು ಮತ್ತು ಕೆಳಗೆ ಮಾಡೋದಾಗ ಕೆಳಗೆ ಮಾಡಬೇಕು. ಪಾದ ಮೇಲ್ ಮಾಡಿ, ಪಾದ ಕೆಳಗೆ ಮಾಡಿ, ಪಾದ ಮೇಲ್ ಮಾಡಿ, ಪಾದ ಕೆಳಗೆ ಮಾಡಿ. Is able to do that, okay, with little difficulty, the dorsiflexion and plantar flexion. Okay, so these are the things which will examine, students: the gait, the arm, the leg, and the spine in the locomotor system, the general examination. And then let us go to the examination of each joint. Okay, right. So let us go to the examination of each joint, students. So first is the cervical spine, then thoracic and lumbar spine. Cervical spine, you will do flexion and extension. Manjunath, cut marchkoli mundukke, flexion, extension, induk marchkoli, extension. And then you have rotation. Manjunath, cut na nodi ಈಗ ಮಾಡಿ ಅಷ್ಟ ಆಗೋದು, ದಟ್ ಇಸ್ ರಿಸ್ಟ್ರಿಕ್ಷನ್, ಸ್ಟೂಡೆಂಟ್ಸ್. ಆ ಸೈಡ್ ಮಾಡಿ ಮಾಡಿ ಆಗಲ್ವಾ, ಅಷ್ಟೇ ಆಗೋದು. ಓಕೆ. and then you ask the patient to touch the ear to the acromion process. ಮಂಜುನಾಥ್, ಈ ಥರ ಮಾಡಿ ಕಿವಿ ಮಡ್ಚಕ್ಕಾಗತ್ತಾ, ಮುಟ್ಟಕ್ಕಾಗತ್ತಾ ಅಲ್ಲಿವರೆಗೂ ಆಗಲ್ಲ. ಓಕೆ, ಇದು ವಿಷಯ ಮಡ್ಚ್ಕೊಳ್ಳಿ. Here also is not able to do that. Okay, right. And then in the spine, as I told, in the galls, you have to look for kyphosis, scoliosis, that you have to look. Okay, right. So in the cervical spine, coming to the thoracic and lumbar spine. So as I told, in the examination of galls, he has to bend forward. The distance between the floor and the finger should be less than 15 centimeter. And the lumbar expansion should be more than 10 centimeter. I have made a lumbar expansion. I have marked here. So these are sacral dimple, students. From here 10 centimeters I marked. Okay, and after he bend it, I measure the distance. This distance from this point to this point is more than 5 centimeters. It is normal. Usually back, the thoracic spine, lumbar spine won't be involved in rheumatoid arthritis. That is why the lumbar expansion is normal in it. So distance between this point and this point is more than 5 centimeters. And then in the lumbar and thoracic spine, you have to look for the rotation and lateral bending. For that, you have to make the patient sit. Okay, ಕೂತ್ಕೊಳ್ಳಿ ಮಂಜುನಾಥ್. ಸಾಕು ಸಾಕು, ಆರಾಮಾಗಿ ನಾನು ಹೇಳೋ ಥರ ಮಾಡಬೇಕು. ಕೂತಿದ್ದೀರಲ್ಲ, ಕೂತಿದ್ದೀರಲ್ಲ, ಹಿಂಗೆ ಬೆಂಡ್ ಮಾಡಬೇಕು, ಹಿಂಗೆ ಬೆಂಡ್ ಮಾಡಬೇಕು. ಆ ಸೈಡ್ ಬೆಂಡ್ ಮಾಡಿ. ಓಕೆ, ರೈಟ್. ದೆನ್ ರೊಟೇಷನ್. Ask the patient to rotate like this and like this. ಈ ಥರ ಮಾಡಿ ಮಂಜುನಾಥ್, ನಾನು ಮಾಡೋ ಥರ. ಆ ಸೈಡ್ ಮಾಡಿ, rotate like this. Right. So these are the things which you look in the spine. Let us come to the examination of the shoulder joint. Shoulder joint, students, the arm should be held like this, and then flexion, then extension. ಮಂಜುನಾಥ್, ನಾನು ನೋಡ್ಕೊಂಡು ನಾನು ಮಾಡೋ ಥರ ಮಾಡಬೇಕು. ಕೈ ಥರ ಇಟ್ಕೋಬೇಕು, ಎರಡು ಕೈ. ಓಕೆ, ರೈಟ್. ಹಿಂಗೆತ್ತಿ ಮೇಲಕ್ಕೆ ಅಷ್ಟೇ ಆಗೋದು. ಆ ಕೈ ಮಾಡಿ. ಯಾ, ಸೊ is a problem in shoulder flexion, students. Both the hands, there's a problem in the shoulder flexion. Let us see shoulder extension. ಮಂಜುನಾಥ್, ಕೈ ಇಟ್ಕೊಂಡು ಹಿಂಗೆ ಮಾಡಬೇಕು, ಹಿಂದಕ್ಕೆ ಮಾಡಿ. ದಟ್ ಈ ಕ್ಯಾನ್ ಡೂ ಎಕ್ಸ್ಟೆನ್ಷನ್. ಈ ಕೈ ಮಾಡಿ. ಯಾ, ದಟ್ ಈ ಕ್ಯಾನ್ ಡೂ ಎಕ್ಸ್ಟೆನ್ಷನ್. ಈ ಕ್ಯಾನ್ ಡೂ, ಬಟ್ ಫ್ಲೆಕ್ಷನ್ there is a restriction both right and left side. Okay, next, rotation in adduction, rotation in abduction. ಓಕೆ ಮಂಜುನಾಥ್, ನಾನು ಹೇಳಿದ ಎರಡು ಥರ ಮಾಡಬೇಕು. ಕೈನ ಹೀಗೆ ಇಟ್ಕೊಂಡು ಫಸ್ಟ್ ನೋಡಿ, ಆಮೇಲೆ ಮಾಡಿ. ಕೈನ ಹೀಗೆ ಇಟ್ಕೊಂಡು ಹಿಂಗೆ ಮತ್ತು ಹಿಂಗೆ ಮಾಡಬೇಕು. ಫಸ್ಟ್ ಒಂದೊಂದು ಕೈಯಲ್ಲಿ ಮಾಡಿ ಸಾಕು. ಈ ಕೈಯಲ್ಲಿ ಮಾಡಿ. ಹಾಂ, ಸಾಕು. ಒಳಗೆ ತಗೊಳ್ಳಿ. ಹಾಂ, ಓಕೆ. ಈ ಕೈಯಲ್ಲಿ ಮಾಡಿ. ಯು ಕಾಂಟ್ ಡೂ ದಟ್, ಸ್ಟೂಡೆಂಟ್. ದ ಲೆಫ್ಟ್ ಹ್ಯಾಂಡ್, ದ ಎಕ್ಸ್ಟರ್ನಲ್ ನೋಡಿ, ಒಳಗೆ ತಗೊಳ್ಳಿ. ದಟ್ ಈ ಕ್ಯಾನ್ ಡೂ ಇಂಟರ್ನಲ್ ರೊಟೇಷನ್. ಸೊ ದಿಸ್ ಅ ರೊಟೇಷನ್ ಇನ್ ಅಡಕ್ಷನ್. Next, the rotation in abduction. Rotation in abduction is done by asking the patient to hold the hand like this in an abducted position, and then the hand should go like this, and then should go like this. Rotation in abduction. ಮಂಜುನಾಥ್, ನಾನು ಹೇಳೋ ಥರ ಮಾಡಬೇಕು. ಫಸ್ಟ್ ಕೈ ಹೀಗೆ ಇಟ್ಕೊಳ್ಳಿ, ಒಂದು ಕೈ ಇಟ್ಕೊಳ್ಳಿ, ಅದು ಒಂದು ಹೀಗೆ. ಓಕೆ, ರೈಟ್. ನಾನು ಮಾಡೋ ಥರ ಮಾಡಬೇಕು. ಹಿಂಗೆ ಮಾಡಿ. ಆಗಲ್ವಾ? ಕೈ ಹೀಗೆ ಇರಬೇಕು. ಆಗಲ್ಲ. ಡಿಫಿಕಲ್ಟ್. ಈ ಸಾರಿಗೆ ಡಿಫಿಕಲ್ಟ್ ಸ್ಟೂಡೆಂಟ್. ದ ರೊಟೇಷನ್ ಇನ್ ಅಬ್ಡಕ್ಷನ್ ಜಸ್ಟ್ ಟು ಬಿ ಡನ್ ಲೈಕ್ ದಿಸ್ ಆ್ಯಂಡ್ ಡನ್ ಲೈಕ್ ದಿಸ್. ದಿಸ್ ದ ಎಕ್ಸ್ಟರ್ನಲ್ ರೊಟೇಷನ್, ದಿಸ್ ದ ಇಂಟರ್ನಲ್ ರೊಟೇಷನ್. ಸೊ ದ್ಯಾಟ್ ಹಿ ಹ್ಯಾಸ್ ಟು ಡೂ ದಟ್. ಓಕೆ. ಸೊ ನೆಕ್ಸ್ಟ್ ಈಸ್ ದ ಎಲ್ಬೋ ಜಾಯಿಂಟ್. ಎಲ್ಬೋ ಫ್ಲೆಕ್ಷನ್, ಎಲ್ಬೋ ಎಕ್ಸ್ಟೆನ್ಷನ್. ಮಂಜುನಾಥ್, ಕೈ ಇದೆಯಲ್ಲ, ಹಿಂಗೆ ಮಡ್ಚಿಬಿಟ್ಟು ಹಿಂಗೆ ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು. ಒಂದೊಂದು ಕೈ ಮಾಡಿ ಸಾಕು. ಮಾಡಿ. ಆಗಲ್ವಾ? ಅಷ್ಟೇ. ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಆಗಲ್ಲ? ಅಷ್ಟೇ. ಓನ್ಲಿ ದಟ್ ಮಚ್ ಯು ಕ್ಯಾನ್ ಡು. ಈ ಕೈ ಮಾಡಿ. ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಮಾಡಿ. ಫುಲ್ ಸ್ಟ್ರೈಟ್ ಮಾಡೋಕ್ಕಾಗಲ್ವಾ? ಆಗಲ್ಲ. ಓಕೆ. ಸೊ ಇಟ್ಸ್ ಅ ಪ್ರಾಬ್ಲಮ್. ರಿಸ್ಟ್ರಿಕ್ಷನ್ ಇನ್ ಎಲ್ಬೋ ಎಕ್ಸ್ಟೆನ್ಷನ್. ಇವನ್ ಎಲ್ಬೋ ಜಾಯಿಂಟ್ ಈಸ್ ಅಫೆಕ್ಟೆಡ್. ಶೋಲ್ಡರ್ ಜಾಯಿಂಟ್ ಈಸ್ ಆಲ್ಸೋ ಅಫೆಕ್ಟೆಡ್. ಎಲ್ಬೋ ಫ್ಲೆಕ್ಷನ್, ಎಕ್ಸ್ಟೆನ್ಷನ್, ಸುಪಿನೇಷನ್ ಆ್ಯಂಡ್ ಪ್ರೊನೇಷನ್. ಕೈ ಹೀಗೆ ಇಟ್ಕೋಬೇಕು ಮಂಜುನಾಥ್. ಒಂದು ಕೈ ಇಟ್ಕೊಳ್ಳಿ ಆದರೂ. ಹಿಂಗೆ ಮಾಡಿ. ಫುಲ್ ಮಾಡಿ. ಆಗಲ್ವಾ? ಯಾ, ಸುಪಿನೇಷನ್. ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಿ ಕೈನ. ಮತ್ತೆ ಹಿಂಗೆ ಮಾಡಿ. ದಟ್ ಇಸ್ ಅ ಪ್ರಾಬ್ಲಮ್ ವಿತ್ ಇವನ್ ಪ್ರೊನೇಷನ್. ಇದು ಅಲ್ಲಾಡಿಸ್ಬಾರ್ದು. ಹಿಂಗೆ ಇಟ್ಕೊಂಡು ಹಿಂಗೆ ಮಾಡೋಕ್ಕಾಗಲ್ವಾ? ಆಗಲ್ಲ. ಓಕೆ, ಈಸ್ ಅ ಪ್ರಾಬ್ಲಮ್. ಈ ಕೈಯಲ್ಲಿ ಮಾಡಿ. ಹೀಗೆ ಹೀಗೆ ಒಳಗೆ ತಗೊಳ್ಳಿ. ಹಿಂಗೆ ಹೊರಗೆ ತಗೊಳ್ಳಿ. Supination is a problem even in the right hand. Wrist joint, wrist flexion, extension, ulnar deviation, radial deviation. ಮಂಜುನಾಥ್, ಕೈ ಇದೆಯಲ್ಲ, ಫಸ್ಟ್ ಬಲಗೈಯಲ್ಲಿ ಮಾಡಿ, ಆಮೇಲೆ ಎಡಗೈಯಲ್ಲಿ ಮಾಡಿ. ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಿ. ಫಸ್ಟ್ ಮುಷ್ಟಿ ಇಟ್ಕೊಳ್ಳಿ. ಹಿಂಗೆ ಮಡ್ಚಿ, ಹಿಂಗೆ ಮಡ್ಚಿ. ಆಗಲ್ವಾ ಹಿಂದಕ್ಕೆ? ಸೊ ರಿಸ್ಟ್ ಎಕ್ಸ್ಟೆನ್ಷನ್ ಇಸ್ ಎ ಪ್ರಾಬ್ಲಮ್, ರಿಸ್ಟ್ ಫ್ಲೆಕ್ಷನ್ ಇಸ್ ಎ ಪ್ರಾಬ್ಲಮ್. ಇದೆಯಲ್ಲ, ಹಿಂಗೆ ತೊಗೋಬೇಕಾಗುತ್ತಾ? It's a problem even in ulnar deviation, the radial deviation, because this joint is predominantly affected in rheumatoid arthritis. Is not able to do most of the movements in the wrist joint, students. In the left also same like this. ಈಗ ಮಾಡ್ಕೊಳ್ಳಿ. ಆಗಲ್ವಾ? ಹಿಂದೆ ಮಾಡಿ. ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ದಟ್. ಹಿಂಗೆ ಮಾಡಿ. ಹೀಗೆ ಮಾಡಿ. ಆಗಲ್ಲ. ದಟ್ಸ್ ಅ full problem with the movement in the wrist joint, students. Next, coming to the movement at the metatarsophalangeal joint flexion, then proximal interphalangeal joint flexion, flexion of the distal interphalangeal joint, whether is able to do that. I take one finger. ಇದೆಯಲ್ಲ, ಹಿಂಗೆ ಬೆರಳು ಮಡ್ಚ್ಕೋಬೇಕು ನಾ ಹೇಳಿದಾಗ. ಮತ್ತು ಇಲ್ಲಿ ಮಡ್ಚ್ಕೋಬೇಕು ನಾ ಹೇಳಿದಾಗ. ಈಗ ಮಡ್ಚಿ ಬೆರಳು. ಅಲ್ಲಲ್ಲ, ಇಲ್ಲಿ 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 ಮಡ್ಚಿ. ಓಕೆ. ಬೆರಳು ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಇಲ್ಲಿ ಮಡ್ಚ್ಬಾರ್ದು, ಇಲ್ಲಿ ಮಡ್ಚ್ಬೇಕು. ಮಡ್ಚಿ. metatarsophalangeal joint, proximal interphalangeal joint, ಇಲ್ಲಿ ಮಡಚಬೇಕು. ಮಡಚಿ. ಇಲ್ಲಿ ಮಡಚಿ. Yeah, you have to look for the flexion at those joints. Then thumb flexion, extension, then adduction, abduction. ಈ ಬೆರಳಿದೆಯಲ್ಲ ಈಗ ಮಡ್ಚ್ಕೋಬೇಕು, ಮಡ್ಚ್ಕೊಳ್ಳಿ, ಮಡ್ಚಿ, ಯಾ ಫ್ಲೆಕ್ಷನ್, ಬೆರಳನ್ನ ಹಿಂಗೆ ಸ್ಟ್ರೈಟ್ ಮಾಡಬೇಕು, ಮಾಡಿ ಎಕ್ಸ್ಟೆನ್ಷನ್, ಹಿಂಗೆ ಮಾಡಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ತೊಗೊಂಬನಿ ಒಳಗೆ ಅಡಕ್ಷನ್, ಹೊರಗಡೆ ತೊಗೊಂಡೋಗಿ ಅಬ್ಡಕ್ಷನ್. ಸೊ ಥಂಬ್ ಮೂಮೆಂಟ್ಸ್ ಯು ಹ್ಯಾವ್ ಟು ಚೆಕ್. ಆ್ಯಂಡ್ ದೆನ್ ಅಪೋನೆಂಟ್ಸ್ ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಿ. So because of the deformities, most of the movements in the hands is restricted, students, 18. So these are the movements which you will check in the arms, okay, in the wrist joint and in the finger joints. Now let us go to the examination in the lower limb, each joint examination. The other two movements which you will check in the shoulder joint is elevation and painful arc. Okay, the elevation, you ask the patient to elevate the hand, the shoulder above the head 180 degree. ಮಂಜುನಾಥ್ ನಾನು ಮಾಡೋ ಥರ ಮಾಡಬೇಕು. ಇಲ್ಲಿ ನೋಡಿ, ನಾನು ನೋಡಿ ಫಸ್ಟು ಈ ಥರ ಮಾಡಿ, ಅಷ್ಟೇ ಆಗೋದು. ಐ ಕುಡ್ ಬಿ ಏಬಲ್ ಟು ಡೂ ಓನ್ಲಿ ದ್ಯಾಟ್ ಮಚ್. ಓಕೆ, ಮಂಜುನಾಥ್ ನಾನು ಮಾಡೋ ಥರ ಮಾಡಬೇಕು. ನಾನು ನೋಡಿ ಹೀಗೆ ಮಾಡಬೇಕು. ಮಾಡಿ, ಅಕ್ಕ ಆಗಲ್ವಾ? Okay, only that much you can do. Left hand is saying very difficult to do that. These two things you have to do that. Now let us go to the examination of the lower limb joints. Malkoli. So students, first I will examine what are the things that can be examined in a sleeping position. Then I will make him stand. Then what can be examined in a standing position, I will show together in the standing position. So hip joint flexion, extension. Then hip joint abduction, adduction. Hip joint internal rotation and external rotation. The internal rotation and external rotation first you can do in a extended position and in a flex position. Both I will show. If internal rotation, external rotation in a flex position, you have to examine in a standing position. I will show how to look for that. Then the knee joint flexion, extension, ankle joint dorsiflexion, plantar flexion, and subtalar joint inversion, eversion, forefoot adduction and abduction. These are the movements which we will check. And in the great toe, torso-metatarsophalangeal joint flexion and extension, I will show that. Right. Hip flexion. ಮಂಜುನಾಥ್ ನಾನು ಹೇಳಿದಾಗ ಕಾಲನ್ನ ಹಿಂಗೆ ಮೇಲೆತ್ತಬೇಕು. ಹಿಪ್ ಫ್ಲೆಕ್ಷನ್ ಸ್ಟೂಡೆಂಟ್, ದಿಸ್ ಇಸ್ ಕಾಲೆತ್ತಿ, ಹಿಪ್ ಫ್ಲೆಕ್ಷನ್ ಸಾಕು. ಈ ಕಾಲೆತ್ತಿ, yeah, hip flexion. Hip extension is in a prone position, okay, that I will do after making him prone, both the hip extension as well as the knee flexion. Now I will do knee extension here. ಕಾಲ್ ಸ್ಟ್ರೈಟ್ ಮಾಡಿ, knee extension. ಕಾಲ್ ಸ್ಟ್ರೈಟ್ ಮಾಡಿ, knee extension. I will examine the foot now and then I will go in a prone position, examine for the hip extension and knee flexion. ಪಾದನ ನಾನು ಹೇಳಿದಾಗ ಮೇಲಕ್ಕೆ ಮಾಡಬೇಕು, ಕೆಳಕ್ಕೆ ಮಾಡಬೇಕು. ಮತ್ತು ಅವಾಗ ಹೇಳಿದ್ನಲ್ಲ, ಈ ಸೈಡ್ ಮುಟ್ಟಿದಾಗ ಇದನ್ನ ಮೇಲಕ್ಕೆ ಮಾಡ್ಕೋಬೇಕು, ಈ ಸೈಡ್ ಮುಟ್ಟಿದಾಗ ಇದನ್ನ ಮೇಲಕ್ಕೆ ಮಾಡಬೇಕು. ಓಕೆ ಮಂಜುನಾಥ್, ಪಾದ ಮೇಲೆ ಮಾಡಿ ಡಾರ್ಸಿಫ್ಲೆಕ್ಷನ್, ಕೆಳಗೆ ಮಾಡಿ ಪ್ಲಾಂಟರ್ ಫ್ಲೆಕ್ಷನ್, ಮೇಲೆ ಮಾಡಿ ಡಾರ್ಸಿಫ್ಲೆಕ್ಷನ್, ಕೆಳಗೆ ಮಾಡಿ ಪ್ಲಾಂಟರ್ ಫ್ಲೆಕ್ಷನ್. ಐ ವಿಲ್ ಡೂ ದ ಇನ್ವರ್ಷನ್. ಈ ಪಾರ್ಟ್ ಮೇಲಕ್ಕೆ ಎತ್ತಿ, ಆಗ್ತಾ ಇಲ್ವಾ? ಇಲ್ಲಿ ಮುಟ್ಟಿದಾಗ ಹಿಂಗೆ ಮಾಡಬೇಕು, ಆಗಲ್ವಾ? ಆಗಲ್ಲ. ಈಸ್ ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ದ ಇನ್ವರ್ಷನ್ ಸ್ಟೂಡೆಂಟ್ಸ್. ಈ ಪಾರ್ಟ್ ಮೇಲಕ್ಕೆ ಮಾಡಿ, ಆಗಲ್ಲ. ಎವರ್ಷನ್ ಇಸ್ ಅ ಪ್ರಾಬ್ಲಮ್ ಇಯರ್. ಇದು ಮಾಡಿ ಇಲ್ಲಿ ಆಗ್ತಾ, ಆ ಥರ ಆಗಲ್ಲ. ಈ ಥರ ಇಲ್ಲಿ ಈ ಸೈಡ್, ಯಾ, ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ದ್ಯಾಟ್. ನಾವು ಐ ವಿಲ್ ಡೂ 4 foot ಅಡಕ್ಷನ್ ಆ್ಯಂಡ್ 4 foot ಅಬ್ಡಕ್ಷನ್. ಮಂಜುನಾಥ್, ಈ ಪಾದ ಇಟ್ಟಾಗ ಇದನ್ನು ಇಲ್ಲಿ ಹೀಗೆ ಹೇಗೆ ಮಾಡಬೇಕು, ಈ ಸೈಡ್ ಮೂಮೆಂಟು ಆಗುತ್ತಾ? ಟ್ರೈ ಮಾಡಿ, ಆದರೆ ಮಾಡಿ, ಇಲ್ಲಾಂದರೆ ಬೇಡ. ಈ ಸೈಡ್ ಮಾಡಿ, ಆಗಲ್ವಾ? ಈ ಸೈಡ್ ನಾಟ್ ಏಬಲ್ ಟು ಡೂ 4 foot ಅಡಕ್ಷನ್ ಅಬ್ಡಕ್ಷನ್ ಸ್ಟೂಡೆಂಟ್ಸ್. ಇದನ್ನು ಈ ಸೈಡ್ ತೊಗೊಂಬನ್ನಿ, ರೈಟ್ ಸೈಡ್, ಆಗಲ್ವಾ? ಆ ಸೈಡ್ ತೊಗೊಳ್ಳಿ, ನೋ, ಆಗಲ್ಲ. ಓಕೆ, ಸೊ 4 foot ಅಡಕ್ಷನ್, 4 foot abduction, not able to do at all. Inversion, eversion, not able to do. Only dorsiflexion, plantar flexion, not able to do. So the movements at the tarsal and subtarsal joints are totally affected in him because of the involvement of the small joints. Now I will make him prone position. I will examine the things which can be done in a prone position. ಈ ಕಾಲ್ನ ಇಲ್ಲಿ ಮಡಚಬಾರ್ದು, ಹಿಂಗೆ ಎತ್ತಬೇಕು, ಮೇಲಿಗೆ ಎತ್ತಿ, ಅಷ್ಟೇ ಆಗೋದು. ಬಿಡಿ. ಈ ಕಾಲು ಎತ್ತಿ, ಓಕೆ, ರೈಟ್. ಸೊ ದಿಟ್ ಇಸ್ ದ ಹಿಪ್ ಎಕ್ಸ್ಟೆನ್ಷನ್. ನಾವು ನೀ ಫ್ಲೆಕ್ಷನ್, ನಾನು ಹೇಳಿದಾಗ ಕಾಲನ್ನ ಹಿಂಗೆ ಮಡ್ಚ್ಕೋಬೇಕು. ನೀ ಫ್ಲೆಕ್ಷನ್ ಸ್ಟೂಡೆಂಟ್ಸ್ ಮಡ್ಚ್ಕೊಳ್ಳಿ. knee flexion, is able to do knee flexion. ಸಾಕು ಸಾಕು ಬಿಡಿ ಸಾಕು. ಇದು ಕಾಲ್ ಮಾಡಿಸ್ಕೊಳ್ಳಿ. ಅಷ್ಟೇ ಆಗೋದು. Right knee has a problem, that's why I am not able to do the knee flexion, students. And one more thing, in prone position I want to tell in the examination of the legs, you have to look for the popliteal fossa and to palpate it for any bursitis. Okay, especially Baker's cyst can develop in rheumatoid arthritis. You have to look for the popliteal fossa and palpate it. ಒಂದು ನಿಮಿಷ ಹಾಗೆ ಮಲ್ಕೊಳ್ಳಿ. Then I'll show here, now the hip is in an extended position. Hip internal rotation, external rotation, in extended position I'll show. ಕಾಲು ಮಡ್ಚ್ಕೊಳ್ಳಿ. ನಾನು ಹೇಳಿದಾಗ ಇದನ್ನು ಹಿಂಗೆ ಹೊರಗಡೆ ಹಾಕಬೇಕು, ಮತ್ತು ಹಿಂಗೆ ಒಳಗಡೆ ತೊಗೋಬೇಕು. ನಾನು ಹೇಳಿದಾಗ ಹೊರಗಡೆ ತೊಗೊಳ್ಳಿ. ದಿಸ್ ಇಸ್ ಹಿಪ್ ಇಂಟರ್ನಲ್ ರೊಟೇಷನ್ ಸ್ಟೂಡೆಂಟ್ಸ್, ಹಿಪ್ ಇಂಟರ್ನಲ್ ರೊಟೇಷನ್. ಒಳಗಡೆ ತೊಗೊಳ್ಳಿ, ಹಿಪ್ ಎಕ್ಸ್ಟರ್ನಲ್ ರೊಟೇಷನ್. ಲೆಫ್ಟ್ ಸೈಡ್ ಫೇರ್ಲಿ ಈಸ್ ಏಬಲ್ ಟು ಡೂ. ಲೆಟ್ಸ್ ಮಿ ಸಿ ಆನ್ ದ ರೈಟ್ ಸೈಡ್. ನಾನು ಹೇಳಿದಾಗ ಹೊರಗಡೆ ತೊಗೋಬೇಕು ಮತ್ತು ಒಳಗಡೆ ತೊಗೋಬೇಕು. ಹೊರಗಡೆ ತೊಗೊಳ್ಳಿ. ನಾಟ್ ಏಬಲ್ ಟು ಡೂ, ಪ್ರಾಬ್ಲಮ್. ಒಳಗಡೆ ತೊಗೊಳ್ಳಿ. ದಿಸ್ ಇಸ್ ಎಕ್ಸ್ಟರ್ನಲ್ ರೊಟೇಷನ್, ದಿಸ್ ಇಸ್ ಇಂಟರ್ನಲ್ ರೊಟೇಷನ್. ಹೊರಗಡೆ ತೊಗೊಳ್ಳಿ. ದಿಸ್ ಇಸ್ ಇಂಟರ್ನಲ್ ರೊಟೇಷನ್. ಓಕೆ ಸಾಕು. ಓಕೆ, ನೌ ಐ ವಿಲ್ ಮೇಕ್ ಹಿಮ್ ಸ್ಟ್ಯಾಂಡ್. ಶೋ ದ ಹಿಪ್ ಅಬ್ಡಕ್ಷನ್, ಅಡಕ್ಷನ್ and hip internal rotation, external rotation in a flexed position. So hip abduction, adduction, I'll tell him how to do it. ಮಂಜುನಾಥ್ ನಾನು ಮಾಡಿದ್ರೆ ಮಾಡಬೇಕು. ನೋಡಿ, ಕಾಲಿಂಗ್ ತೊಗೊಂಡು ಹಿಂಗೆ ತರಬೇಕು ಮಾಡಿ. ಹಿಪ್ ಅಬ್ಡಕ್ಷನ್ ಇಟ್ಕೊಳ್ತೀನಿ ಮಾಡಿ. ಹಿಪ್ ಅಬ್ಡಕ್ಷನ್, ಹಿಪ್ ಅಡಕ್ಷನ್ ಎಷ್ಟಾಗುತ್ತೋ ಅಷ್ಟು ಮಾಡಿ ಅಷ್ಟೇ. ಈ ಕಾಲು ಮಾಡಿ. ನಿಧಾನಕ್ಕೆ ತೊಗೊಳ್ಳಿ. ನಿಧಾನಕ್ಕೆ ತೊಗೊಂಬನ್ನಿ. ಹಿಪ್ ಅಬ್ಡಕ್ಷನ್, ಅಡಕ್ಷನ್. ನೆಕ್ಸ್ಟ್ ಇಂಟರ್ನಲ್ rotation, external rotation in a flex position. Ask the patient to flex the thigh like this, then hip internal rotation, hip external rotation. ಕಾಲು ಮಡ್ಚ್ಕೊಳ್ಳಿ. ನಾನು ಮಾಡ್ತಾರ ಹಿಂಗೆ ಮಡ್ಚ್ಕೊಳ್ಳಿ. ಹಿಂಗೆ ಇದು ಸ್ಟ್ರೈಟ್ ಇರಬೇಕು. ಹಿಂಗೆ ಆಗಲ್ವಾ? ನಾಟ್ ಏಬಲ್ ಟು ಡೂ ದ್ಯಾಟ್. ಈಸ್ ಟೆಲಿಂಗ್ ಅನೇಬಲ್ ಟು ಡೂ ದ್ಯಾಟ್. ಈ ಕಾಲು ಮಾಡಿ ಹಿಂಗೆ ಮಡ್ಚ್ಕೋಬೇಕು. ಹೊರಗಡೆಗೆ ಒಳಗಡೆಗೆ ತರಕ್ಕಾಗುತ್ತಾ? Anyway, he has a difficulty in doing that. He is finding difficulty in doing that. That's the reason. Then in sleeping position, I want to test for two tests. One is the SLRT test. I'll do that. Okay. And on standing position, I'll test for a Trendelenburg test. Okay. Trendelenburg test is ask the patient to stand on the one leg. Normally, the opposite hip will elevate. A normal person. Suppose if the patient is standing on one leg, if ipsilateral hip joint is a problem because of dislocation or rheumatoid arthritis or any arthritis problem, the contralateral hip will go down because of the hip abductors on the affected side, gluteus medius and minimus. Okay, ಮಂಜುನಾಥ್ ಈ ಒಂದೇ ಕಾಲ ಈ ಥರ ಹಿಂಗೆ ನಿಂತ್ಕೊಳ್ಳಿ. ಈ ಕಾಲ ನಿಂತ್ಕೊಳ್ಳಿ. Yes. So you have to see for the hip position. Here it is normal, it is not sagging down. Okay, if it is a problem of the hip joint, the contralateral hip will sag down. This is Trendelenburg's test. And for the spine test, IVDP, one is SLRT commonly which you do. So let me do SLRT on him on sleeping position. ಮಂಜುನಾಥ್ ಈ ಕಾಲು ಇದೆಯಲ್ಲ, ಎತ್ತಬೇಕು ಮೇಲಕ್ಕೆ. ಎತ್ತಿ. ಏನಾದ್ರು ಪೇನ್ ಇದೆಯಾ? ಬ್ಯಾಕ್ ಪೇನು ಇಲ್ಲ, ನೋ ಪೇನ್. ದಿಸ್ ಈಸ್ ಲಿಫ್ಟಿಂಗ್ ದ ಲೆಗ್. ಈ ಕಾಲು ಎತ್ತಿ. ಪೇನ್ ಇದೆಯಾ? ಬ್ಯಾಕ್ ಪೇನು ಇಲ್ಲ. Okay, right. So SLRT is negative. Okay, 45 degree, even if more than 45 degree, he is not having any pain in the back. For IVDP, SLRT will be done. Okay, and you can dorsiflex it, then it becomes a Lesigus sign. It is a reinforcement for the IVDP test, Lesigus sign. Usually back won't be involved in rheumatoid arthritis except the atlantoaxial joint. Okay, that's why they won't have most of the signs which is pertaining to the back in rheumatoid arthritis. So these are the examination of the each joint which we will do. Okay, so he has most of the problems in the small joints, even the big joints, upper limb shoulder joint, elbow joint, lower limb knee joint, he has a problem. So now let us go to the other system examination, students. The respiratory system examination, inspection, trachea is central, apex beat is in 5th intercostal space, no chest deformities, the shape of the chest is normal. Palpation, the measurements are normal, shape of the chest is normal, bilateral symmetry it is there, chest movements are normal, chest expansion is normal, vocal fremitus is normal. Percussion, there is a resonant note all over the lung field. Auscultation, normal vesicular breath sounds are heard. No added sound and no bronchial beating. What are the specifically you look in respiratory system in rheumatoid arthritis? Whether they have any pleural effusion. Pleurisy is the commonest manifestation of respiratory system involvement. So signs of pleural effusion you have to look. Interstitial lung disease, usual interstitial pneumonia and non-specific interstitial pneumonia are the two commonest affection of the lung. So you have to look for any crepitation is there or fine crepitation. For that you have to look in a rheumatoid arthritis patient. Cardiovascular system examination, inspection, apex beat in the fifth intercostal space, no visible pulsations. Palpation, apex beat is a normal in character, no parasternal heave. Percussion, heart borders are normal. Auscultation, S1, S2 is heard, and there is no added sound. So, what are the specific things you look for cardiovascular system examination in rheumatoid arthritis? The pulse rate, they can have a bradycardia due to the nodules, as well as the amyloidosis, which can affect the heart, they can have a bradycardia. Then myocarditis can produce a heart failure. So any signs of heart failure is there, you have to look. Okay. And then the commonest valve regurgitation which you can get in rheumatoid arthritis is mitral regurgitation. So whether he has any murmur, you have to look for that. Per abdomen inspection, normal in shape. All the quadrants move equally with respiration. No engorged veins, scar or sinuses. Palpation, there is no organomegaly. Percussion, there is no shifting dullness or fluid thrill. Auscultation, vowel sounds are heard and it is normal. What are the specific things you look for per abdomen in rheumatoid arthritis? Suppose rheumatoid arthritis is one of the causes of secondary amyloidosis, so you have to look for hepatosplenomegaly. And one of the extra-articular manifestation of rheumatoid arthritis is lymphoma. So whether patient has any splenomegaly or hepatomegaly, pertaining to that angle, you have to look for abdominal examination in rheumatoid arthritis for hepatosplenomegaly. Central nervous system, high mental function is normal. Cranial nerve examination is normal. Motor system, arm, forearm, calf muscles are very small in him, probably because the pain is not using it. That is the reason why he is having a pain. Then tone is normal, the power is normal, the deep tendon reflexes, superficial is normal, coordination is normal, and sensory system examination is normal. No cerebellar signs. And gait, I'll examine in the gait, I'll explain in the end when I'll make him talk about the gait. And no evidence of mononeuritis multiplex. Especially the CNS manifestation rheumatoid arthritis is one of the cause of mononeuritis multiplex. So you have to look whether any single nerve is damaged, and carpal tunnel syndrome it can produce. So and peripheral neuropathy they can get. So peripheral neuropathy signs, mononeuritis multiplex, you have to look specifically in a rheumatoid arthritis patient. So this is the examination of this case. Okay, and now let us go to the examination of the gait. In the end, I'll explain the gait. So students, now we discuss the case. Okay, let me tell about a few important points about the rheumatoid arthritis. Rheumatoid arthritis is a chronic inflammatory arthritis of unknown etiology. It is the most commonest cause of the inflammatory arthritis. Okay, and rheumatoid arthritis is having extra-articular manifestations. It is characterized by anti-citrullinated, anti-cyclic citrullinated antibody, anti-CCP antibody. And in our patient, the anti-CCP antibody they have done, it is around more than 98. Okay, and even RF factor is positive in him around 60. Anything more than 18 is taken as a positive rheumatoid factor. Okay, so he's having both RF factor positive as well as anti-CCP positive our patient. So rheumatoid factor, the age of the onset is between 25 to 55. The incidence will keep on increasing. From 55 years to 75 years, it will plateau down. After 75 years, the incidence will reduce it. Female to male ratio incidence is around 7 to 1 or 8 is to 1, around that range between a female to a male patient. Okay, so usually they'll have because it's the inflammatory arthritis, there will be early morning stiffness of more than 1 hour duration, which after which the pain will reduce or the stiffness will reduce with the activity. It may start with a single joint or a oligoarthritis or a polyarthritis, which later becomes a symmetrical arthritis. Initially, there may be only a few joints involved, which is classified under undifferentiated arthritis. Later, they will turn into a rheumatoid arthritis. The common joint which will be involved in rheumatoid arthritis are metacarpophalangeal joint, first interphalangeal joint, the wrist joint, and tarso-metatarsal joints. If the distal interphalangeal joint is involved, then you have to think osteoarthritis, not rheumatoid arthritis. arthritis if the distal interphalangeal joint is involved. Then the rheumatoid arthritis will have extra-articular manifestations, which I'll discuss later. The atlanto-occipital joint involvement usually won't produce a neurological deficit, but 10% atlanto-occipital joint can be involved. The tender joints and the swollen joints indicate the disability and the disease progression in future if they are more tender joint, okay, and swollen joints. Temporomandibular joint, radiologically there may be a abnormality, but clinically usually temporomandibular joint won't manifest. The extra-articular manifestations you get in 30 to 40% of the patients that may precede the onset of rheumatoid arthritis, or it may come along with the rheumatoid arthritis. Of late, extra-articular manifestations incidence is reducing, especially the vasculitis and the Felty syndrome. Extra-articular manifestation is more common those who are having a more physical disability like our patient, and those who are smokers, and those who are having RA factor positivity and anti-CCP positivity. So let us discuss about the extra-articular manifestations. The commonest extra-articular manifestation is the constitutional syndrome, as I told. They will have fatigue, malaise, fever, weight loss because of the increased inflammation. Fever more than 1 or 2 degree Fahrenheit is rare. If fever is there more than 1 or 2 degree Fahrenheit, then you think of either active infection or vasculitis. The next extra-articular manifestation is subcutaneous nodules. You see in around 30 to 40% of the patients. Subcutaneous nodules are present in the friction areas like in the forearm, the Achilles tendon, and sacrum areas. They are painless, they are benign, but they can ulcerate and gangrene can be formed. Subcutaneous nodules not only present in the tendon sheath, in the periosteum, it also present in the lungs, lung parenchyma, the parietal pleura, the cardia, peritoneum, it can be present. The subcutaneous nodules is more common in the patient who are having a more disease disability, though in those who are having RA factor positivity, and there are some genetic epitopes, shared epitopes, okay, in those people subcutaneous nodules is more common. Of late, the incidence of subcutaneous nodules is reducing. It is reducing. The next common extra-articular manifestation is the lung manifestations. The pleura is the commonest to involve. They will have a pleuritis and exudative pleural effusion. They will have interstitial lung disease, two types, usual interstitial pneumonia and non-specific interstitial pneumonia. In a usual interstitial pneumonia, the peripheral part and the lower part of the lung will be involved, showing a honeycomb appearance. And in a non-specific interstitial pneumonia, they will have traction bronchiectasis. Both will have a reduced diffusion for carbon monoxide capacity will be reduced, and both will produce a restrictive lung pattern in a pulmonary function test. As I told, nodules can occur in the lung parenchyma. If they have silicosis along with the pulmonary nodules, it is known as a Kaplan syndrome. The next extra-articular manifestation is a Sjogren syndrome. It is seen in around 10% of the patients. They will have dry eyes and dry mouth, Sjogren syndrome. It is secondary Sjogren syndrome. Next is cardiological manifestations of rheumatoid arthritis. Coronary artery disease is the commonest cardiological manifestations. They can have pericardial involvement with the pericardial effusion. And myocarditis, they can have necrotizing and granulomatous myocarditis, producing a heart failure. Nodules, as I told, can occur in the heart also, producing the blocks. And amyloidosis can also affect the heart, producing the blocks. Next extra-articular manifestation, vasculitis. Vasculitis, of late, it is reducing the incidence of vasculitis. It is seen in around 1% of the patients, especially those who are having a high disease activity and decreased complement, and those who are having a long duration of the disease more than 1 year. Vasculitis will manifest with a mononeuritis multiplex or a skin manifestation like petechiae, ecchymosis, gangrene, ulceration, livedo reticularis. The next extra-articular manifestation is the anemia. Our patient is having anemia. The investigation showed he is having hemoglobin of around 8 to 9 grams. It varies between that. That is due to anemia of chronic inflammation. The severity of the anemia directly proportional to the severity of the inflammation. So if the anemia is severe, they will have a high ESR and high CRP level. They will have a increased platelet count as an acute phase reactant, They'll have increased platelet count, and thrombocytopenia is rare. Autoimmune thrombocytopenia, like Evans syndrome, is rare in rheumatoid arthritis. Felty syndrome is another histological manifestation, rare in a country like India, common in European countries, seen in females, less than 1% of the patients. They'll have neutropenia, nodular rheumatoid sclerosis, and splenomegaly. So, nodular rheumatoid arthritis, splenomegaly, and then neutropenia. Felty syndrome comes in the latest stage of the disease of rheumatoid arthritis, whereas a similar picture like a large granular lymphoma can occur in an early part of the rheumatoid arthritis. There are also patients who have neutropenia. The only differentiating feature is LGL comes in the early part of the rheumatoid arthritis, whereas Felty syndrome occurs in the later part of rheumatoid arthritis. Apart from these two conditions, neutropenia is rare in rheumatoid arthritis apart from a drug toxicity. Next is a large B-cell lymphoma. Especially those who are having a Felty syndrome and high disease activity, they can develop lymphoma, large B-cell lymphoma. These are the extraarticular manifestations of rheumatoid arthritis, and there are some associated conditions like the cardiovascular diseases, osteoporosis, and hormone abnormality relevant to FSH and LH. Cardiovascular abnormality, they can have CAD and CHF students because of the high inflammation, as I told, and that is one of the commonest cause of death in rheumatoid arthritis apart from infections. Osteoporosis, joint inflammation will spill the inflammation to the whole body, so they can have osteoporosis because of high inflammation, as well as because of the immobility and corticosteroid usage. Then they'll have low FSH and LH because corticosteroids will inhibit the FSH and LH, and even dihydroepiandrosterone also can be less, and low testosterone can be there in rheumatoid arthritis patients. Now, how is the disease epidemiology and etiology? As I told, the male to female ratio is around 7 or 8:1. It's an unknown etiology for rheumatoid arthritis. But some etiological factors which have been hypothesized, smoking is one of the etiology. Then cytomegalovirus, streptococcal infection. Then gingivitis is one of the latest topic in rheumatoid arthritis. One organism, Porphyromonas gingivalis, has been implicated in rheumatoid arthritis because this Porphyromonas gingivalis will citrinate the arginine by an enzyme known as peptidyl arginine deaminase, and this enzyme is present only in that organism. So that is of late our latest hypothesis in the rheumatoid arthritis etiology. Now, coming to the disease progression, in 10% of the patients, the disease can have a self-remission in 10% of the patients. The cause of death will be usually coronary artery disease or the infection. Those who are having a more tender, swollen joints, and those who are having the erosions in the X-rays, those are the ones who will having a more physical disability. And in whom the mortality is more is those who are having extraarticular manifestations, low socioeconomic status, low income, low educational status, and those who are having a chronic steroid therapy for longer period of time. Those are the ones who are having a bad prognosis in rheumatoid arthritis. How do you diagnose a case of rheumatoid arthritis after you examine clinically? The American College of Rheumatology or a EULAR criteria, it has made a criteria for diagnosing rheumatoid arthritis. First, the four things which it will include is the joint involvement, then acute phase reactants like CRP and ESR, then the serology, the anti-CCP or rheumatoid factor, then the duration of the illness. Coming to the joint involvement, if 0 to 1 large joint is involved, the score given is 0. If 1 to 10 large joint is involved, the score given is 1. If 1 to 3 small joints are involved, in that the metatarsophalangeal joint, metacarpophalangeal joint, proximal interphalangeal joint, and the proximal first interphalangeal joint of the thumb, if it is involved, the score given is 2. If 4 to 10 small joints are involved, the score given is 3. And if more than 10 joints are involved, in that at least one small joint, the score given is 5. So remember, there is no 4 here. 0, 1, 2, 3 and 5. Then coming to the serology. If anti-CCP is positive or if RA factor is positive more than 3 times, less than 3 times. If it is neutral positive, point is 0. If it is less than 3 point elevation, then score is 2. If more than 3 times the elevation, the score is 3. Remember, here there is no 1, only 0, 2, 3. Now coming to the acute phase reactant, CRP and ESR. If it is elevated, the point given is 1. If not elevated, 0. The duration of the illness, more than 6 weeks, less than 6 weeks. If less than 6 weeks, 0 point, more than 6 weeks, 1 point. If total addition of the points is more than 6, then it is a rheumatoid arthritis. The latest American College of Rheumatology doesn't involve the X-ray features or subcutaneous nodules as in the criteria, and it involves anti-CCP antibody, which is more specific. These are the two changes compared to the previous guidelines for the diagnosis of rheumatoid arthritis. Rheumatoid factor is a IgM frequently, but very rarely it can be IgG, IgA. Frequently it is IgM, or it can be IgG or IgA also, or IgT also. Rheumatoid factor can be positive in some of the other conditions apart from rheumatoid arthritis like SLE, mixed cryoglobulinemia, subacute bacterial endocarditis, normal individuals, and hepatitis B patients. It is positive in 70 to 80% of the patients rheumatoid factor. Both rheumatoid factor as well as the anti-CCP have a similar sensitivity, but anti-CCP is more specific. So doing both as an incremental value, because some patients will have rheumatoid factor positive but anti-CCP negative. Some will have anti-CCP positive, rheumatoid factor negative. So we have to do both anti-CCP as well as rheumatoid factor. And both have a diagnostic and prognostic significance, especially anti-CCP as a mortality and a high severity prognosis. It indicates anti-CCP antibody. So which are the other tests you do? Suppose if there is a joint involvement with the inflammation, you can do a synovial fluid analysis. The synovial fluid cells will show somewhere between 5,000 to 50,000 cells here because it is an inflammatory arthritis. In an osteoarthritis, the synovial fluid cells will be less than 2,000. Then X-ray of the involved joint can be done. X-ray will show the joint space narrowing, subchondral erosions, soft tissue swelling will be there. These are the X-ray features of rheumatoid arthritis. Soft tissue swelling, subchondral erosion, joint space will be narrow, and effusions will be seen. Then ultrasound. Ultrasound is better in picking the erosion than the X-ray. Of late, ultrasound has gained the importance, and ultrasound can also detect the synovitis. MRI of the joint can be done, which will indicate the bone marrow edema because of the inflammation, joint effusion, and synovitis. Synovitis can be indicated by increased vascularity. These are the investigations which you can do in rheumatoid arthritis. Coming to the approach to the patient, how do you manage it? The methotrexate, first I will tell the drugs and then I will go to the management. The drugs, students, here you have NSAIDs, which will be given symptomatically to treat the pain. They have both analgesic as well as the anti-inflammatory properties, the NSAIDs. Then corticosteroids. Under 4 scenarios, you give corticosteroids in rheumatoid arthritis. One is a bridge therapy. The disease modifying agents which you will give will take time to act. Till they act, you give as a bridge therapy the corticosteroids. Or if they have extra-articular manifestations, you give corticosteroids. To prevent the disease flares, suppose the disease has flared up, to prevent that, you give corticosteroids. Or if a single joint is involved, intra-articular corticosteroids you can give. Under these scenarios, you give corticosteroids. Then coming to the disease modifying agents. The conventional disease modifying agents are methotrexate, hydroxychloroquine, sulfasalazine. Of late, leflunomide has come. And why they are called as disease modifying agents? Because they alter the progression and structure of the disease of the rheumatoid arthritis. Whereas NSAIDs and steroids are only symptomatic benefit. These, the natural disease progression, they alter the disease modifying agent. They prevent the structural damage to the joints. Leflunomide will take time to act around 6 to 12 weeks. So the conventional DMRDs are SCQs, sulfonamides, and then methotrexate, the first choice of drug. SCQ doesn't prevent the bone erosion, so it is not in a true term, it is not a proper disease modifying agent. Leflunomide and methotrexate are having an equal efficacy, whereas hydroxychloroquine can be given only an add-on therapy or as an adjuvant therapy. Sulfasalazine is having the same efficacy like that of a SCQ, hydroxychloroquine. Then you have biologicals. The biologicals are the one is chimeric, that is infliximab, then humanized adalimumab, golimumab, and then you have a chimeric, that is certolizumab. Rituximab is another monoclonal antibody. Anakinra is another monoclonal antibody. Abatacept, then you have rituximab, abatacept, and small molecules like JAK inhibitors, JAK1 and JAK3 inhibitors, tofacitinib. Then you have IL-6 antibody, tocilizumab. I'll explain each one of them. These tumor necrotic factor monoclonal antibodies are infliximab, adalimumab, golimumab, certolizumab. They can be given either as a monotherapy or as a combination therapy, except infliximab. Infliximab should be always given with a combination therapy with the methotrexate, whereas the other anti-tumor necrotic factor monoclonal antibody can be given as a monotherapy, including etanercept, which is a tumor necrotic factor receptor antagonist. These monoclonal antibodies, before giving, there are some contraindications. If there are active infections like bacterial, tubercular, or fungal, you should not give it. Or if they have any allergic reaction to these monoclonal antibodies, you should not give it. Or if the hepatitis B or stage 3 and 4 heart failure, you should not give the monoclonal antibodies. IL-1 monoclonal antibody is an anakinra. That you should not combine with the other monoclonal antibody because that increases chance of infections. Then you have abatacept, which is a domain of CTLA4. It inhibits the co-stimulation of the T cells by blocking CD28, CD80, and 86. There is an increased chance of infection if combined with the other monoclonal antibodies. So you have to give either with a methotrexate or as a monotherapy. IL-6 monoclonal antibody, tocilizumab. Probably now because of COVID, you are used it in COVID patients. It's the same monoclonal antibody. The adverse effects are neutropenia, thrombocytopenia, and increased cholesterol. Then you have rituximab, can be combined with the methotrexate, the rituximab. Then small molecule inhibitors which act on the messenger, the post-cellular, the messenger. JAK1 and JAK3 inhibitor, tofacitinib. This also has a lipid abnormalities, neutropenia, LFT, and even serum creatine can be elevated in tofacitinib. Then how do you approach a patient with rheumatoid arthritis? How do you start the treatment? How do you monitor the treatment? Usually divided into early and established case of rheumatoid arthritis. So in a first detected early case of rheumatoid arthritis, the first line of management is methotrexate. Methotrexate decreases the release of adenosine, by which it acts as an anti-inflammatory drug. So you give for 3 to 6 months of methotrexate. If no response, there are 3-4 options. You give a triple disease modifying agents. You club methotrexate with the hydroxychloroquine or sulfasalazine, or you give methotrexate plus leflunomide, or you start methotrexate with a monoclonal antibody. If oral disease modifying agents are not effective, then you can always try a biologicals after 3 to 6 months. Then how do you monitor the therapy of the rheumatoid arthritis patient? There is a score, disease activity score, DAS28 score. Then American College of Rheumatology has defined the remission as the patient should not have any articular or extra-articular manifestation of inflammation or immunological markers. The definition is the tender joint should be less than 1, the swollen joint should be less than 1, CRP level should be less than 1 milligram per deciliter, or the patient global assessment should be 1. They'll score from 1 to 10, the patient assessment and visual assessment of the rheumatoid arthritis. So the patient global assessment should be less than 1, or they'll say disease specific activity score should be less than 3.3. The disease specific activity index should be less than 3.3. What the disease specific activity index includes? The disease specific activity index includes 4 parameters. One is they'll take 28 joint involvement in the body. Then CRP level they'll take, that should be less than 1, or they'll score it, how much is the level. Based on that, they'll score the specific disease activity index. Then patient global assessment and physician global assessment from 0 to 10 points. They'll score it. That index should be less than 3.3, then only patient is in a remission. That is the definition of remission of American College of Rheumatology. Then some specific scenarios you should know how do you treat rheumatoid arthritis, especially in a pregnant lady, females. The drugs which you should not give in pregnancy is two drugs. One is lefranamide, another is methotrexate. So you can give hydroxychloroquine, sulfasalazine, steroids. Even biologicals should not be given in pregnancy according to Harrison's. 70% will improve in pregnancy, and post delivery there will be a flare up for the rheumatoid arthritis. Then in old age patients, one third of the patients will have a diagnosis of rheumatoid arthritis after 60 years. The disease modifying agents and biologicals act similar efficacy in old age people also, but they have a more incidence of infections, and drugs can produce renal toxicity, especially NSAIDs, and methotrexate should not be given if the serum creatinine is more than 2. So these are some of the points about rheumatoid arthritis, students. So it's a very nice case for you with all the deformities. And I told in the beginning only how to approach a case of arthritis. Okay, Harrison has given a beautiful flow diagram chart which I explained in the history. So read that chart and you see this video with all the deformities. Read in the Harrison nicely given. Okay, about rheumatoid arthritis. So it will be kept as a short case, or even in a DNB exam can be a semi-long case. And is one of the commonest inflammatory arthritis in our practice also. And you get a lot of cases of rheumatoid arthritis in your practice. And hope this discussion should help you. Thank you.